Another topic I wanted to just go into a little bit here is I want to talk about LHON genetic testing. Genetic testing can be a complicated and costly part of the LHON journey. This talk is to review some of the genetic testing options you may encounter, the benefits and drawbacks of each option, and some of the labs which offer them. So on the screen, there's a representation of the mitochondria, and it's possible to test for just one single targeted mutation, or you can do what's called a panel test, where the lab tests for several mutations at one time, and another option is to sequence the entire mitochondrial genome. Why would you do a targeted mutation test? It's to confirm the maternal relative, to quickly determine if you're eligible for a clinical trial, benefits, lowest cost, fastest turnaround. But the drawback is there's additional testing required if the results are not positive to achieve a diagnosis. So the next largest opportunity is a panel of mutations. It tests for some of the most common LHON mutations. It's used to confirm a clinical diagnosis of LHON when no specific mutation in the family is known. Benefits, it's commonly used. Doctors are familiar with it. Drawbacks, additional testing may be required to achieve a diagnosis if results are negative. So this is just an example of a panel test where it says that a person is positive for a certain mutation. And this is an example of a panel test where it just says that none of the mutations tested by that panel testing found a mutation. So then what's the next option is to go to mitochondrial genome sequencing, which tests the entire mitochondrial genome, and that can again confirm a clinical diagnosis, and it identifies common and rare mutations, but it can be more expensive than a panel test, although costs have declined over the years. One of the other issues that comes into play with making choices and learning about genetic testing is a concept called homoplasmy and heteroplasmy. Many tests simply confirm the presence or absence of LHON mutations, but other tests provide information about something called heteroplasmy. And I'm going to turn to Dr. Newman and ask her if she would do that, please. Explain it and what the implications are.
So remember the schematic we had, and there's a little something up there as well, that the nucleus gets half of its genetic material from mom and half from dad, right? And that's the way it happens every time they have a kid. There's a little bit crossover stuff, but basically you get half from dad, half from mom. The mitochondrial DNA, which is in the mitochondria, and there are hundreds of mitochondria in each cell, how do you get your mitochondrial DNA? Well, when you've got your zygote, which is mom and dad's nucleus together, and mom's cytoplasm, the cell will divide, and will divide, and will divide, and will divide. And we know when cells divide, you get exactly the same nuclear materials split in half. You all remember our biology. But the cell cytoplasm, this part of the cell where the mitochondria are, it divides like a bud, like bacteria's divide. It just buds. And so you could have some mitochondria in that bud and some mitochondria in that bud. And if your mutation in your mitochondrial DNA is relatively new, like it happened spontaneously, then you could have some mitochondria that have wild type or normal mitochondrial DNA, and some mitochondria that have the abnormal or mutant mitochondrial DNA. And depending on where those particular mitochondria are floating around in the cell, when the cell divides, you could end up with a cell that has 80% mutant and 20% normal, or you could end up with a cell that has 50% mutant and 50% normal. And so it's kind of a willy-nilly sort of division. Now, and that's called heteroplasmy. Homoplasmy is the mitochondrial DNA is the same in every cell and every tissue. Heteroplasmy means that there are different concentrations of both normal and abnormal mitochondrial DNA within a cell or within a tissue, usually is how it refers. Now, in general, life, the way we know it in humans, usually progresses to homoplasmy very quickly. And in studies that we've done, heteroplasmy as part of Leber's hereditary optic neuropathy accounts for no more than 15% of pedigrees. And even then, we're testing blood, or we're testing urine, or we're testing buccal swabs. We're not testing the optic nerve, where it may already be 100% homoplasmic. So just by testing blood, even with that, only 15% of pedigrees or less will have a form of heteroplasmy. So what does that mean? It means that if you get Leber's and there is nobody else in your family who has Leber's, and you're positive for a mutation, and especially if you're positive for the mutation and there is some element in your blood of heteroplasmy, it is not unreasonable to have your mother checked. If your mother is 100% homoplasmic, then the likelihood is all the siblings also carry the mutation, right? So she would be the best one to check, rather than check the individual siblings necessarily. However, if you're found to have the Leber's mutation, and we know that an uncle lost vision in your family, it's ridiculous for you to have your siblings checked, or your mother checked for that matter, because everybody on the maternal lineage is going to carry that mutation. And that was one of the things I was going to say when you're talking about being a carrier. I think it's important to know which mutation you have. But unless the person who's involved in your family is what we call a singleton case, the only person who's ever had vision loss from Leber's and there's been no one else tested, unless you're in that setting, I don't think anybody on the maternal lineage actually needs to be tested. And I think the consensus statement we came up with that we mentioned earlier says that. Most Leber's experts will tell you you don't really need to get tested. You just need to know what your mutation is. Now, to get into a clinical trial, because of the rules of that, they will test you. Even if you know what your mutation is, even if you've been tested before, they have to have a lab that they have contracted with get a result specifically that says what your mutation is. So they're going to test you for a clinical trial. But it can certainly move things along faster and get you into the clinical trial faster if you already know what your mutation is and that mutation is eligible.
And that's why I was saying earlier, know your mutation, not telling everyone to go get tested. Because people have reasons not to get tested. Maybe you don't want to have it in your medical record. There's GINA in the US that should protect you against health, but who knows what'll happen tomorrow. And having something in your record and that makes you predictably more likely to lose vision, does that affect your opportunity for long-term disability or other insurance? I don't know. And putting it in your record might mean something, but being prepared and knowing your mutation without doing the test is a different option. A heteroplasmy report example, this is just an example of a test where someone does have like 69% mutated mitochondria. So it shows, that is I showed earlier some examples of homoplasmy, and it's also possible to see heteroplasmy. When it comes to lab options, again, your cost, insurance, the lab's financial assistance options, turnaround times vary widely, whether the sample is FedExed for a buccal swab or a blood draw, and whether or not the lab reports heteroplasmy are all reasons to consider. I've just pulled together some of the labs to have it here that are currently doing LHON testing, so you have them as reference, and you and your doctor or genetic counselor may have reasons to use certain labs. Some of the ones that as of May of 2019, these were some labs in the US testing for LHON. Athena Diagnostics, for instance, does a panel of the 3 major mutations. They do a blood draw. They were doing a 2 to 3 week turnaround at the time. They do offer the Athena Alliance program for financial assistance. Carver Lab in Iowa also does a panel test of the 3 main mutations. It's a blood draw. It's a 6 to 8 week turnaround, so it's longer, but it's a nonprofit lab and they only charge $140. And I've known people that have wanted to get testing done and have balked at the price of a commercial lab, but they've heard of the $140 price with Carver and have found that to be an attractive option. EGL Genetics does full mitochondrial genome sequencing with a blood draw and an 8-week turnaround. GeneDx does both blood draw or buccal swab, and they have a variety of payment plans. They're actually here at the conference downstairs if you want to talk to them, and they do the various tests I've talked about, the target variant, the panel, and the full mitochondrial genome sequencing. NMG does both the target test and the mitochondrial genome sequencing. And again, a neuro-ophthalmologist, ophthalmologist, primary care physician, or genetic counselor can order the tests. Dr. Anemic, can you talk a little bit about why some people order a panel test and why some order the full mitochondrial?
Yeah, so if we have a known family history and you know the mutation already, then it's really often, if you have a classic presentation of labors, I'm not even sure it's necessary to order a blood test unless you're part of a clinical trial. So that's number one. Number two is you have an absolutely classic, even with family history, but no one's ever been tested. In that situation, what I do is I order the panel, which is the 3 primary mutations that account for about 90% of all cases of labors, and I order it in what I call, in a form that's called a reflex test. A reflex test means that they will test that panel, and if it is positive, they stop, if it's positive for one of the 3, and if it's negative, they know my clinical suspicion is high enough that I want them to move on to the full sequencing of the mitochondrial genome. So hopefully the person taking care of you will have an option to do that, because it keeps you from having a second blood draw, and it keeps things moving along, so you don't have the delay of getting the result that's negative, coming back, getting another blood draw, and then going back. So that's what I usually do. So I never just order a full mitochondrial sequencing, because I find that that's a waste of money. But you still want to know that. And if someone's not all that typical, I will just do the panel, where I'm thinking, gee, maybe it's that, but there's a lot of compelling evidence that it could be something else. If it's just one eye, so it's just the first eye, and it's not the clinical profile that I usually do, but I'm suspicious enough that I want to get the test cooking, I'll just order the panel.
Thank you. And is there anything else about the topic of genetic testing you want to add before I wrap up that piece?
No, if there are questions, I'm happy to answer it. The people who go sort of hunting for heteroplasmy because they think it may make them associated with a lesser chance of either having lost vision or, so first of all, if you're heteroplasmic and you've lost vision from labors, it doesn't mean you're going to have a better course or necessarily a better chance of recovery. It may mean that that your chance of having the vision loss to begin with might have been less, but remember, we're checking cells in your mouth or cells in your blood, not your optic nerve. So you may be homoplasmic in your optic nerve. It may make no difference. So I really don't see the importance necessarily of looking for heteroplasmy.
Thank you. So we have 10 minutes left, and if the microphone runners would like to grab them, we have 10 minutes for questions on anything about anything we've been talking about.
I wanted to know, have you ever seen any families with multiple diagnoses with different mutations? Or are they always the same mutation?
Yeah. So the short answer is one is enough. The longer answer is there are case reports of families even with 2 primary mutations. So both the 11778 and the 14484, for example, which we've reported papers, but that's the whole point, is you report papers on people like that. It's very rare. The group in Italy has just come up with some really groundbreaking stuff, which luckily only relates to very few people, but there are people with classic pedigrees of labors, classic clinical presentations, who not only don't have the 3 primary mutations, but when you sequence their entire mitochondrial genome, there do not appear to be a single pathogenic mutation that fits the bill for pathogenesis, which is a very complicated process to figure out what's a pathogenic alteration in the mitochondrial DNA or not. And what they've shown very convincingly, very rarely, a certain combination of variants in the mitochondrial DNA sequence that normally would, each one by themselves, would not fit would not cause disease. When put together, like 3 or 4 of them in a lump, will actually cause vision loss. But that is so rare, and it's it's what they have found looking very deeply into this thing. The bottom line is 90% of people with Leber's will have one of those 3 mutations, and I would say another 8% are going to have a primary mutation, in the sense that all you needed was this one abnormality to cause the vision loss, but it only accounts for vision loss in 1 or 2 pedigrees worldwide. But don't go hunting for another one. You don't need it.
My question is in relation to atypical juvenile onset. So is there any research towards that or treatment recommendations for juvenile onset that is not the typical central vision loss?
Well, usually even juvenile onset will have central vision loss. It may be more slowly progressive, or it may be that the child is too young to let you know when it's first starting up. It really depends on what you mean by juvenile. So those who are 10 and younger,
Yeah, 8.
yeah, those who are 10 and younger, in general, the bad news is they're 10 or younger and they have this disease. The good news is that they have a much better prognosis for spontaneous recovery, even with the 11778 mutation, and certainly with the 14484 mutation. When you say research, there's not really enough of them to do a trial just on them. I think that, Xavier, you'd have to help me with this. What is the youngest patient with Leros? Was it 12 that you allowed in?
I think it was 12, yeah.
Yeah. So there are, as far as these clinical trials, mostly because of regulatory agencies, we do not include patients that young. The other reason is because their chance of recovery is so great. How will we know whether it was what we treated them with that got them better or not, or whether it just was going to be the natural history? And that's been the big criticism of the Chinese study, because they've let really young kids into this therapy of being injected in the eye, where we think they might have gotten better on their own. Now, having said that, if I had a kid come to me and they were a 11778 kid, because we know that idebenone is not harmful in children that age, because that's the age of the kids with Friedreich's ataxia, upon whom there were multiple trials of idebenone, since I do not think it is a danger, I might recommend that they be treated. I wouldn't know the correct dose. I would involve a pediatrician. I'd look at the original Friedreich ataxia trials to see what the dosage was in children. I'm not saying it's going to cure them. I'm not even saying it's going to change the natural history, that they would have gotten better anyway, but I would at least give them the chance.
I have a question about how early, how early you can identify in the clinical setting that Leber's is affecting you. The picture that Lissa showed us where just a tiny little part of that picture was faded. Yeah. How early can you say, oh yeah, that's not a floater?
Well, floaters move around. That doesn't move around. But it's a really good question, because, in retrospect, I know so many of you feel like your doctors were stupid, or they just didn't know, or they were dumb, or they are even negligent, I hate to say. But the reality is that our visual system, just like many other parts of our body, has only a few ways of saying it's not happy. And blurred vision, even blurred vision centrally in a little spot, can happen from lots of different things, including maybe some of you have heard of the macula. You have maculopathy, something wrong with the very center of the retina. People with type A personalities, they get a little fluid between the layers of their retina. It will look just like that. And so you've got to be examined. Now OCT helps us figure out where the problem is. We can figure out if it's an optic nerve problem or a retinal problem, or you've had a little bleed in your vitreous, or you've got what I did the other day. I got a thumbprint on my contact. You know, I mean, those things, they all will look subjectively to you exactly the same. Now, if you're a carrier, you're going to be hyper aware of those things. And if you have a doctor you go to who knows you are a carrier, they may be able to do early testing, which will indeed suggest A, it's optic nerve, and then B, because of your family history, this is likely not optic neuritis. You know, lightning can strike twice, right? You're allowed to have an optic neuropathy from something other than Leber's, but the chances are that's what it would be. But it could rule out the maculopathy, for example, or the smudge on the contact lens. Yeah.
At the beginning, you were talking about IDBN, and you were saying that at least the study showed that after you had better result in the 1 to 5 years range and in the first year. So does that mean that we should continue as long as we can? And you said, I don't prescribe it after 24 months. So why and like what should we do?
So you have to remember what that data was. So that was taking patients who were treated for 6 months, and then looking backwards retrospectively to see how many of those at 6 months were 2 lines better than they were at baseline. And they found that about 30% of the patients treated with idebenone at 6 months were 2 lines better. Doesn't tell you how many were 2 lines worse. We're just talking about 2 lines better. And 10% of those treated with placebo were 2 lines better. And then when they looked at the group at 1 year and from 1 to 5 years, so it's not that these patients were treated for 1 to 5 years with idebenone. They were only treated 6 months. And it just basically showed that those, for reasons I can't quite fathom, that those who were already more than a year out from their vision loss had a better chance of being that 2 lines better 6 months later being treated with idebenone than not only those who had not been treated at all, but by those who were treated who had only lost vision within the year. It doesn't make a lot of logical sense, so it's a little hard to extrapolate that, but to the company's credit, they're trying to look into those who have still been treated for longer than 6 months to see if the curve plateaus, to give them an idea of when it should stop.
Okay. So that's the reason why you're not saying go beyond 24 months, because there's nothing showing.
Right now, I don't have any good data that tells me for sure that it keeps getting better after it's basically the 2 years. Remember we said you can do it you get it on and then you take it the extra year. But it's a very good question.
I'm just,
Go ahead and talk and I'll find you.
I'm
Okay.
over here.
Yeah,
I'm
okay.
here. I'm just curious how long you personally have been ordering the reflex test or panel, because we came to you 10 years ago, and with my daughter, and we still aren't quite sure what mutation she had.
So
And
it
they did do a blood draw at Emory.
Yeah. Did they do the full mitochondrial sequencing?
think
I don't
so.
think so
No.
because
It was in 10 years.
I don't think the full mitochondrial sequencing was available 10 years
Right.
ago. So I can get the reflex via Emory because I'm there.
Right.
But even just to order full mitochondrial sequencing, I don't think we've had it much longer than 10 years available.
Thank you.
Would you be willing to speak about hormone replacement therapy for middle-aged women who are either carriers or are affected?
Sure. So if Rustam were up here or Alfredo, they might speak differently than I, but I'm only going to speak the way I can, right? So let me explain where the question is coming from, if I may. So there is some in vitro work, meaning not in a human being work, that suggests that estrogen may be protective of mitochondrial function. I think that's the simplest way of putting it. And it therefore has suggested that that may be one of the reasons that women who carry the mutation may not express it will not express the mutation with vision loss as often as men. It's also been argued that there's something on the X chromosome that is protective in women, and that somehow modifies expression. Regarding the estrogen, if you truly believed that it was a major role, then I would, even though women tend to have a slightly later average age at onset when they do lose vision than men, it's not like they're losing it postmenopausally. I mean, many of you in this room have lost vision who are women, and it wasn't after menopause. So I think that if it were a real major contributor, then we'd be seeing a totally different peak in age for women, and it would be after menopause. So to get back to your question, I think what you're asking is, do I recommend that postmenopausal women carriers specifically take estrogen hormonal therapy? And my answer is no, I do not. I certainly wouldn't say you shouldn't do it. If you were going to do it anyway, that's fine, but I do not believe that there is a lot of science clinically behind it. I'll tell you what I think. Right. Here.
Yeah, we've got lots of questions, but I don't know if you can stay a few more minutes, but you need to go, and well, because but I was going to say there's a lot of folks that are heading out for dinner, and they have a restaurant reservation, and they need to get there, and I think, okay, so I think, one more, all right, sure.
I'm on. Hello? I'm sorry, this is a naive question, I guess, to the point, but something you said kind of struck me where you said if you go get the blood test, whether it's just for a specific gene or for the panel, that doesn't in itself do a diagnosis, doesn't it?
Oh, yeah, it does. Well, I certainly didn't mean to say that. If you clinically have the picture of Leber's and you get a blood test that's positive for one of the 3 primary mutations, that clinches the diagnosis.
It does for me too, thank you.
So we need to get people going various places. If you can squeeze in a question or two with Dr. Newman before she runs out, perhaps. However, what I want to say is thank you, Dr. Newman.